Hello, this is Eric Strong once again, and today's lecture in this course on understanding ABGs will focus on the topic of respiratory acidosis. The learning objectives of this lecture are to know the factors which control alveolar ventilation and to know the differential diagnosis of a respiratory acidosis. Before I jump into the long list of conditions in the differential diagnosis of a respiratory acidosis, a general discussion of the mechanism of respiratory disorders is going to be beneficial towards achieving a more complete understanding of their pathophysiology as it relates to acid-base balance. Almost all primary respiratory disorders arise as a consequence of either one of two general problems. Either the respiratory centers of the brain fail to appropriately process physiologic data that would otherwise tell the body to increase or decrease ventilation in response to changes in gas exchange, or there is an inability to change ventilation in response to appropriate signals from the respiratory centers. Another way to look at this is that respiratory disorders originate from either the source of the signal to increase or decrease ventilation, the apparatus that responds to this signal, or the means of communicating that signal from the former to the latter. Control of ventilation is a complex process in which the medullary respiratory center integrates input from various locations in the brain, as well as sensory impulses from a variety of peripheral chemoreceptors and mechanoreceptors. The result of this integration is the medulla's direction to the muscles of respiration as to the rate, depth, and pattern of ventilation. The most important of these central respiratory inputs are the central chemoreceptors, located in a variety of locations but most prominent on the ventral surface of the medulla. These chemoreceptors detect changes in pH and stimulate either an increase or decrease in ventilation in order to drive pH back to normal. For example, detection of a dropping pH from a metabolic process will stimulate an increase in respiratory drive. Greater ventilation will lead to lower PaCO2, as we will discuss more in a minute when reviewing the alveolar ventilation equation. And the lower PaCO2 will push the arterial pH higher as dictated by the Henderson-Hasselbalch equation. This is the basic mechanism of respiratory compensation that we have frequently referred to in previous lectures. The cerebral cortex also provides input. First, a variety of circumstances can lead to increased ventilatory drive from the cerebral cortex, such as pain, anxiety, or intentional hyperventilation. While it's impossible to consciously hypoventilate for a sustained period of time, the cerebral cortex is thought to provide a low-level tonic inhibitory signal, the purpose of which is not clear. In the pons are two additional respiratory centers, the actions of which are also not completely understood, but in the simplest terms, they are believed to mildly antagonize one another in order to fine-tune tidal volume and respiratory rate. These inputs are distinctive in that communication with the medullary respiratory center is bidirectional. Finally, there is significant empiric evidence that there exist progesterone receptors in the CNS and that stimulation of these receptors increases ventilation. In the periphery, the most important input comes from peripheral chemoreceptors in the carotid and aortic bodies. The carotid bodies are more active in adults, while the aortic bodies are more active in infancy and early childhood. These peripheral chemoreceptors detect changes in PCO2 and pH. They also detect changes in PO2, sending pro-ventilation signals once PO2 drops below 75 millimeters of mercury, which become particularly strong once PO2 drops below 50 millimeters of mercury. Fortuitously, high PO2 levels do not result in an inhibitory signal. Otherwise, providing excessive supplemental oxygen, as which frequently occurs in the hospital, could result in patients ceasing to breathe. While much less important, there are other peripheral receptors. Juxtacapillary receptors, more commonly referred to as J receptors, are present in the alveolar interstitium and are activated by pulmonary edema and increased interstitial fluid. Mechanical stretch receptors in the smooth muscle of the airways initiate a decrease in respiratory rate in response to overdistension, a process known as the Herring-Brewer reflex. Finally, there are irritant receptors in the airway epithelium which activate in the presence of histamine, prostaglandins, and a variety of exogenous noxious chemicals. So what is the net consequence of this complex process? The consequence is that high PCO2, low pH, low PO2, pain, anxiety, pulmonary edema, histamine, inhalation of noxious chemicals, and elevated levels of progesterone all lead to increased ventilatory drive. Low PCO2 and high pH lead to decreased ventilatory drive. Another angle from which we can approach the physiology of ventilatory control is to review the alveolar ventilation equation. This equation mathematically relates ventilation with the partial pressure of carbon dioxide in arterial blood, which is our most significant window into understanding a patient's ventilation status available at the bedside. This equation states that the PaCO2 is equal to the rate of carbon dioxide production, denoted as V.CO2, times the total pressure of inspired air, divided by alveolar ventilation, denoted as V.A. Alveolar ventilation, which is a measure of the rate of delivery of inspired air to perfused alveoli, is equal to the respiratory rate times the difference between the tidal volume and dead space. This equation and these terms are discussed more in Lecture 2 from the course on mechanical ventilation, for those of you who are interested in more background. But in brief, tidal volume is the total amount of air inspired with each breath. The dead space is the volume of gas in the lungs which does not participate in gas exchange, either because it is not adjacent to a diffusing membrane or because that section of the lung is not being adequately perfused. From this equation, we can see that mathematically there are 4 types of derangements that will lead to increased PaCO2: low respiratory rate, low tidal volume, high dead space, and high rate of CO2 production. Of these, the first 2 account for the overwhelming majority of respiratory acidoses, and the last 2 very rarely. Although the equation suggests that high pressure of inspired air can also lead to high PaCO2, this would only occur in unusual non-physiologic situations such as hyperbaric chambers, and we won't consider it further in this lecture. At this point, I'm going to move on to the list of specific etiologies of a respiratory acidosis. Unfortunately, this is by a large margin the longest differential diagnosis among the 5 fundamental acid-base disorders, and not every etiology will be explicitly listed. First, there is obstructive lung disease, such as COPD and asthma. While moderate to severe COPD is frequently associated with a chronic respiratory acidosis, asthma only leads to this during severe exacerbations. Next is the category of central hypoventilation. These are primary problems located in the brainstem. The most common of these is drug intoxication. The list of drugs which can lead to respiratory depression in toxic levels is very long in itself. The big 3 drug classes here are alcohol, narcotics, and benzodiazepines. Other classes occasionally implicated in respiratory depression and its subsequent acidosis include the so-called non-benzodiazepines, such as zolpidem or Ambien, histamines, gabapentin and the similarly structured pregabalin, and various antidepressants and antipsychotics. There are various brainstem lesions which can occur as a consequence of trauma or stroke. Obesity hypoventilation syndrome is also associated with central hypoventilation. And finally, central hypoventilation syndrome, also known as Ondine's curse. The next category is neuromuscular diseases. These can be seen in the spinal cord, peripheral nerves, the neuromuscular junction, or the muscles. I won't go through every cause listed, especially since this represents only a small subset of these conditions. The next category is diseases associated with poor compliance of the total respiratory system. They can be further divided into those which result in low lung compliance, such as the various forms of interstitial lung disease, acute lung injury and ARDS, and lesser degrees of pulmonary edema. And those diseases which result in low chest wall compliance, such as kyphoscoliosis. Obesity hypoventilation syndrome also belongs here, as I'll discuss in a few minutes. The final category is not a problem with ventilation at all per se, but is rather hypermetabolism, that is, rare situations in which the rate of CO2 production is significantly elevated over normal. This has been reported in extreme fever, prolonged seizures, and hyperalimentation. This list is obviously very long, and it may be a little bit intimidating. Also, there is no clear algorithm to follow in order to reach a diagnosis like there was with each of the metabolic disorders. Luckily, however, the vast majority of conditions listed here are either individually quite rare or have other features of the presentation which will drive the diagnostic workup towards something rather specific. Therefore, I'd like to focus on just those entities which I most frequently encounter in my clinical practice, which are COPD, drug overdose, and the obesity hypoventilation syndrome. COPD is a complicated disease which could be discussed for hours, so I'm just going to focus on how COPD leads to a respiratory acidosis. To get there, however, I need to first review the two classic subtypes of COPD. There is chronic bronchitis, represented by this man here, who was historically referred to as a blue bloater, and there is emphysema, represented by this guy, known as a pink puffer. While many textbooks and medical school lectures may give the impression that it is easy to distinguish these two subtypes at the bedside, in reality, most COPD patients fall along a spectrum between these two extremes. The primary physiologic problem from the chronic bronchitis component is airway inflammation, while the primary problem from the emphysema component is parenchymal destruction. Airway inflammation leads to increased airway mucus and some degree of fibrosis, while destruction of parenchyma leads to decreased outward traction applied to the airways. These two processes together lead to airway obstruction. Since this obstruction is more pronounced during expiration, there is subsequent air trapping and hyperinflation. This hyperinflation causes the development of positive end expiratory pressure, which can help to improve oxygenation, but which also creates additional work for the respiratory system during inspiration. It also leads to flattening of the diaphragm, which through multiple mechanisms also increases respiratory work and decreases overall efficiency of ventilation. The consequence of this is lower tidal volumes. While the body attempts to compensate for this with increased respiratory rate, when the progression of COPD has moved past the earlier stages, this compensation will be incomplete. Incomplete compensation for low tidal volumes necessarily means decreased alveolar ventilation. The destruction of lung parenchyma mentioned earlier also leads to decreased surface area of the alveolar capillary membrane, which can directly contribute to decreased alveolar ventilation by increasing dead space. Lower alveolar ventilation, as we know from the alveolar ventilation equation, must result in higher PaCO2. Chronically elevated PaCO2 may result in decreased sensitivity in the central respiratory centers to further changes in PaCO2, which then feeds back and can increase PaCO2 still further. All in all, the process by which a respiratory acidosis develops in COPD is fairly complicated. The next etiology of a respiratory acidosis is drug overdose. As with COPD, this is far too expansive a diagnosis to discuss in depth. However, let's just focus on the depression of respiration. As a general rule, drugs that depress respiratory drive first lower the respiratory rate, and only at higher levels lower tidal volume as well. The risk of significant respiratory acidosis and death is relatively low when a single drug is present, but each additional drug that's added synergistically impacts ventilation, particularly when the additional drugs are in different classes. For example, mixing alcohol, narcotics, and benzodiazepines. Here is a simple qualitative graph in which the relative risk of fatal drug overdose will be plotted in arbitrary units as a function of the number of drug classes simultaneously present in a person's circulation. With only one drug class, the risk, as mentioned, is small. With two classes, the risk is substantially higher, higher in fact than simply adding the risk of each individual class together. Finally, with alcohol, narcotics, and benzos all present simultaneously, the risk of accidental fatal overdose is high. If you're unconvinced by this arbitrarily qualitative graph, I'll put together another set of non-scientific qualitative data, a list of some of the major celebrities who have suffered accidental overdoses after combining multiple respiratory depressants. These drugs were all available either over the counter or were provided by a physician. Marilyn Monroe, who some may claim actually committed suicide, died after mixing the prescription sleep aid chlorohydrate with barbiturates. Jimi Hendrix died after mixing barbiturates with alcohol. Anna Nicole Smith mixed chlorohydrate, multiple benzodiazepines, and Benadryl. Michael Jackson, in a highly questionable move by his now disgraced physician, was given the powerful anesthetic propofol mixed with multiple benzodiazepines. Heath Ledger, who in my opinion is the most unfortunate soul on this list, made a fatal miscalculation when he combined multiple narcotics, multiple benzos, and the over-the-counter antihistamine doxylamine. Whitney Houston mixed the benzo Xanax with Benadryl and the sedating muscle relaxant Flexeril, though it may have arguably been the stimulant cocaine that dealt her the fatal blow. Finally, and most recently, the American artist Thomas Kinkade died after mixing alcohol and the benzodiazepine Valium. While this list isn't exactly a rigorous scientific study, it supports the notion that accidental death as a consequence of mixing multiple respiratory depressants isn't a rare phenomenon. Next, I'd like to talk about the obesity hypoventilation syndrome, which may be much less common among the rich and famous, but which is not rare in the general population and which frequently goes unrecognized. Obesity hypoventilation syndrome, or OHS, is simply defined as the combination of obesity and chronic hypoventilation while awake that occurs in the absence of other explanations. Hypoventilation occurs due to two factors. First, there is poor compliance of the chest wall that leads to a form of restrictive lung disease. Second, there is decreased central responsiveness to changes in PaCO2 and PaO2. It's as if the brain decides that too much physical effort is required for the body to maintain normal ventilation, and it resets itself to accept a higher PaCO2 before triggering a sensation of shortness of breath. Despite a frequent assumption to the contrary, obesity hypoventilation is not the same thing as obstructive sleep apnea. Obstructive sleep apnea, or OSA, is caused by physical upper airway obstruction during sleep and is characterized by normal gas exchange while awake. There is, however, substantial overlap between the two syndromes, which we can demonstrate with a simple Venn diagram. This blue circle will represent patients with OSA, and the red circle patients with OHS. This demonstrates three things. First, that OSA is much more common than OHS. Second, that the majority of patients with OSA do not have OHS. And third, the majority of patients with OHS do have OSA. Frequent complications of OHS include chronic hypoxia, pulmonary hypertension, right heart failure, and a predisposition to develop hypercapnic respiratory failure, often without any clear precipitant. I'd like to conclude this lecture with a brief discussion of the rare but historically interesting condition central hypoventilation syndrome, which is also known as Ondine's curse. This is a rare impairment of autonomic control of ventilation, but with intact voluntary control. Affected patients are sometimes said to forget to breathe when they fall asleep. It's best described in its congenital variant, but it can also be acquired as a consequence of surgery, trauma, or stroke. The interesting part of this condition is the origin of the eponym, which is one of the few medical eponyms that is not the name of a physician. The name Ondine's curse actually comes from a German folktale. In a story known as Sleep of Ondine, Ondine is a beautiful and immortal water nymph who falls in love with a mortal man. He swears faithfulness to her with every waking breath, and they are married. Unfortunately, after bearing his child, Ondine loses her immortality and begins to show signs of aging. A little too stereotypically, the man then has an affair with a younger woman. When Ondine discovers them together, she uses her magical powers to curse him that since he swore faithfulness with every waking breath, if he should fall asleep, that breath would be taken away and he would die, which of course he eventually did. Since central hypoventilation syndrome wasn't described until the 1960s, it is unlikely the writers of the folktale were referencing a specific medical condition. That's it for this lecture on the causes of respiratory acidosis. Please continue to the next lecture that will briefly discuss the causes of respiratory alkalosis, the list of which is much shorter.